Hello and welcome to Read Scholars Live. I'm your host, Dr. Mary Fleming, and current president of Read Scholars. Today we are joined by Dr. Keila Lopez. Dr. Lopez is currently a practicing pediatric cardiologist at Texas Children's Hospital and serves as the director of transition medicine and pediatric cardiology at Baylor College of Medicine in Houston, Texas. She received her medical degree from Rush Medical College in Chicago and completed her pediatric residency at the University of Chicago before her fellowship in pediatric cardiology at Baylor, Texas Children's Hospital. Dr. Lopez is a Reed Scholar, finishing the fellowship in minority health policy in 2008. And she seeks to incorporate cardiology, public health, technology, and minority health policy in order to develop research initiatives that directly inform health policy, improve the healthcare of underserved and minority populations. A mouthful. So welcome, Dr. Lopez. How are you today?
Thank you very much. I'm well. Things are moving right along here in Texas.
And so tell us a little bit about your day-to-day. How's life been for you over the past few months?
Well, it's been a shift. Things have changed quite a bit. I mean, at least for a little while. We, at the Children's Hospital, had to have some significant shifts in terms of how we took people out of clinical rotations, kind of tightened the ship so that we would have less people potentially exposed to COVID, because, children are largely known to be asymptomatic carriers. And so you don't know if they are infected or not. And so we were trying to minimize the amount of potential physicians who were affected or infected by COVID by making a smaller skeleton team. And now we've kind of getting back to normal now that the governor has opened up a lot of the different services. Elective surgeries are now reopened, et cetera. We're kind of getting back to normal, although there's a lot of things that are still not normal. There's the schools remain closed. A lot of daycares remain closed. And now some of the businesses, non-essential businesses, are just starting to open back up. And so, what ends up happening now, and if we have to kind of go back to what we were at previously, it remains to be seen. But for now, it's sort of business as usual is what they're telling us. They're trying to make it. So we'll see.
Fair enough. And, as you know, we are recording our mini podcast series on digital health and health equity as part of our Health Equity Symposium series that we usually have annually every year. And so one of the things we wanted to talk about is your interest in digital health as a part of health equity. And so I know you work primarily as a pediatrician, right, with children and adolescents, and I know you have a special interest in teenagers. So can you tell us a little bit about how you've been working with them around technology and especially around chronic diseases and teenagers?
So I did go into pediatrics because kids are the best, and so they're pretty fun to work with. Interestingly, not everybody likes teenagers to work with as a group, but I have to tell you, they're probably the most dynamic and honest group that you can probably work with. That's part of the reason that I like them so much. And my interests in terms of working with teenagers and working in technology really stemmed from the disparity that I saw in that group. And I work in pediatric cardiology, and so a lot of these children are born with congenital heart disease or born with heart problems. And once you're born with a heart problem, you may have it palliated or you may have some repairs done, but you still have to see a cardiologist, pediatric or adult congenital cardiologist for the rest of your life. And so finding the space to navigate between the two worlds of pediatric and adult has proved to be very, very challenging for this group. That improved with the Affordable Care Act and the ability to stay on their parents' insurance and the ability to not have a limit on their insurance based on pre-existing conditions. But there still is a very enigmatic black box on the adult side for a lot of these pediatric patients who have known only one system. And so my goal was to improve the journey, if you will, between the pediatric and the adult sides and trying to navigate that gap between the two. We were losing a lot of our patients in terms of loss to follow-up once they left our system. And then we'd say, what happened to you? Have you seen a cardiologist? And the answer is no. Or they'd end up in the ER. They'd end up in our ER, even though they were 30. Things
Wow.
like this. And so it's a really big challenge. And so to try to improve that, the way to really get to working with youth is through technology. And so that was the impetus for working with youth on technology and using technology to kind of leverage their ability to use it to stay in care.
And you mentioned the Affordable Care Act, and that was another shift in technology and how we interface with it in the medical field. So we've talked a little bit on some other podcasts about how electronic medical records have been around for a little bit, right? But there was a huge push for everyone to get electronic medical records at that time, and how that changed a little bit of our workflow from day to day, to say the least. But in addition to that, we talk a lot about when we build systems in a system that already has a lot of inequities, and how to not build bias in the system as well. So can you speak a little bit from your perspective about that shift, and why it was important, but how sometimes it can increase barriers and include bias, but what are our opportunities at the same time?
Sure. So I'm sure many people are aware of the HITECH Act. It was something that the government introduced in 2009 as a part of the Meaningful Use program. It was a part of the Affordable Care Act. And meaningful use, as they termed it, was to help increase the use of an electronic health record. And the incentive to do that was to try to improve the safety and quality for patients, to improve transparency, to allow for people to engage more in their healthcare, for improved care coordination, and to understand things on a larger level, a population health level. And they were hoping that by having more robust data systems that would occur. And so the other unique thing that they did is that they tied incentives to the use of those electronic health records. And so suddenly people went from not using it at all to using it a whole lot, because a lot of reimbursement was tied to the use of those electronic health records. And then as a secondary to that, as a corollary to that, in 2012, the Big Data Research and Development Initiative was started as a piggyback to that HITECH Act. And that was to try to, again, leverage through the use of electronic health records and biometric data and administrative claims records to try to understand different patterns in population health, to try to understand if there was anything amidst this complex data that we could glean to improve population health. That was the impetus for that push through the Affordable Care Act. And so, some of this you've actually seen leveraged with the COVID situation. A lot of the data that was gained from who is dying, who exactly is doing worse in this COVID outbreak, and understanding that there was grave disparities for African Americans, for Latinos, for individuals with comorbid conditions.
Right.
A lot of that information came from having these databases that people could then leverage and see. And so in a lot of ways, that data can be helpful. But as you stated, depending on who is leveraging the data and how they are leveraging the data, can really change whether or not big data can assist in either reducing health inequities or making them worse.
And interesting, just as an aside, so because I get to travel around doing locums, and I've seen many different EHRs over the course of the past few years, they're not all created equally. Even if they have the same name, doesn't mean they're actually the same functionality.
That's right.
And they don't, and I think patients entering the system often think that they all are synced and are intertwined, and they're not, right? So it's interesting that the perception is like, well, you already have my information. It's in the computer, right? It's in the computer. And it's like, well, even within the same systems, the EHRs often don't communicate with each other. And so sometimes it improves input, but the output and the interfaces don't always work very well. So I think that's still challenging.
One of the oldest EMRs that exists, or EHRs that exist, is the VA system.
Yes, that's very true.
And there remain grave disparities in the VA system as well. And so, that just goes to show that just because you have some communication between systems does not necessarily mean that a lot of these health disparities are eliminated. How you use the data and how you help individuals based on that data have a lot to do with the outcomes. Saying that there's a problem and then doing something about it, those are two very, very different things.
That's very true. And the other thing you mentioned, and I wanted to expound upon a little bit about what data we have. So even though we have the ability to get the data, are we getting all the data? And then what are we doing with that data? And so one of the populations that often gets left out of this conversation, she talked a little bit about the populations that we talk about traditionally with health disparities with Black and African American patients, Latinx patients, Native American patients, but we haven't talked a lot about the undocumented population. So can you speak a little bit to the challenges specifically to that population and how, in light of COVID-19, which is, illuminated many of our health disparities, how that is continuing to either perpetuate or exacerbate the problem, depending on how you look at it?
Sure. I'll just go back and say, during the prior administration, there was some trust that was built in that community, in the undocumented community, about the ability to trust the government to work on their behalf to try to help them. And that was particularly true for the DACA individuals. Those are the individuals who were brought here as children and were illegal, but they were brought here as children. So the dreamers, if you will, those are the individuals who then were asked to submit their data to be able to help them on a path towards citizenship, or at least on a path towards education, because a lot of the stuff that they were hoping to get, they just didn't have access to. They didn't have access to aid for college. They didn't have access to any insurance, Medicaid insurance. If they were lower socioeconomic status, they didn't have access to any of these things. And so in an effort to improve that, the government said, please, we will help you. And then that changed, the administration changed. And so some of that data that was then previously used to help was then concerningly changed to potentially harm or not help, depending on how you look at that
Right.
population. And so that population became very, very fearful of having given their data. And this is what happens when something changes at a governmental level. And so the degree of distrust in the undocumented community, which undocumented is a lot of different communities. Most people subscribe that only to Latinos, but it's actually many, many different races and ethnicities. That has grown tremendously in the current era. And so as a result of this, the ability to do things like COVID testing, tracking and tracing has become much more challenging in that community. In that community, a lot of those individuals are essential workers. A lot of them are the individuals working on the front lines. And so to then not be able to track and trace them and have them go back into their communities where it is much more challenging to socially distance, many of them live in crowded housing, and that's been demonstrated over and over in New York. In New York City, there's a recent article that came out demonstrating who are the people that, despite 10 weeks of social distancing, are still being adversely affected. And the answers were individuals with comorbid conditions, the elderly, and in New York City, the lower SES individuals and Latinos. Those were the individuals who are being most adversely affected currently, despite all the social distancing, because social distancing is harder when you live in one bedroom apartment, or when you're an essential worker, or getting those individuals tested is much more challenging when they're scared. Yeah. And even for individuals who are not undocumented, if you are someone who has a cousin who's undocumented, or an uncle who's undocumented, or a spouse who's undocumented, your likelihood of going and saying they're having these symptoms, please test them, and then trying to help is really hindered. And some of that is in part due to what's happened recently in terms of the mistrust. Right. And we've seen mistrust in the medical system before. We've seen mistrust with African Americans and experiments like, the Tuskegee syphilis experiment and things like this. There's a lot of different ways that you can build mistrust, and I think that has grown pretty significantly unfortunately, in that community, and puts them at a much greater risk for having untoward events with COVID.
And then, and speaking about messaging, especially as well, one, understanding well, unfortunately, we haven't had a singular message around the pandemic, but even when the messaging has been more concise and necessarily hasn't been available and relevant to all our population. Speaking to your point about social distancing and how do you interpret that, right? When you go home and you're living with 5 or 6 people, right? And if you don't have room to not sleep in the same room, or you have to go to work, or somebody has to go to work, and you don't have any place else to go. And I think it's unfortunate that we haven't been very specific to give messaging that's going to actually help. There are large segments of the population that's almost like wasted words because they can't do anything with it. So being in Houston, big metropolitan area, right, with lots of people. I know you've done some work with the mayor's office around, kind of going forward with this, using this to help us hopefully improve the lives of vulnerable populations going forward. Can you talk a little bit about that experience and what do you see on the horizon there?
Sure. I mean, luckily, here in Texas or in the South, I think we've had the advantage of seeing what has occurred in the Northeast and saying, okay, this is what's happening in the Northeast. We have got to get a hold of this before it happens again in other large cities. And as you stated, we're the 4th largest city in the United States. And so in Houston. And so Mayor Turner took very, very seriously what he was saying regarding a lot of these disparities that were coming out of news reports from New York, Chicago, New Orleans, etc. Mm-hmm. And so he put together the HER task force, the Health Equity Response Task Force. And there's a variety of different subgroups and subcommittees in that task force, some of which are faith-based, community-based groups, some of which are technology-based groups. I am on the medical subcommittee as well as the public health subcommittee. And so trying to leverage these different areas within these different areas of expertise as well as different groups together to say, how can we minimize the effects of COVID so that it does not disproportionately affect communities of color. And that was what, or lower SES communities. And that was what the impetus was for the HER task force. And so thus far, we've met probably 4 times so far. And we're now getting together different documents. We have subgroups within the subgroup, and we're working together to decide what is the messaging that we would like to get to. What is the best way to reach different communities? Reaching African American communities. The strategy is, I think, somewhat different than reaching Latino communities and reaching Asian communities. We have the largest population of Vietnamese outside of Vietnam in Houston. Wow. There's lots of large communities, and as a matter of fact, Houston is the most diverse city in the nation. And so as it comes to messaging, making sure that you target appropriately for each different community is really, really important. Being culturally sensitive to those communities is also very, very important. And so getting individuals from each community that are well-known, respected, and then being able to go in and say, what can we do to help you? What would best help you? And how can we keep you safe is a lot of the stuff that we're working on. Some of that comes through technology. And some of the issues that we talked about is a little more challenging. Like we've been talking a lot about undocumented individuals and how do we convince them to get tested and convince them that their data will not be used outside of this particular area and that it will be destroyed and it will not go into the hands of ICE or other individuals in the name of public health. And we've been trying to talk a lot about how do we get education to these populations when some of the things that are more challenging, like social distancing, are not able to be done. What do you do? What do you say? And how do you help these communities? And so the good news is that there's so many different voices and there's so many different individuals that are represented that it really has become a nice amalgamation of what this is Houston. It's like a nice quilt work of the various communities and the various groups in Houston that really do want to work together to improve outcomes that we've seen being so disparate in other areas. And so we're hoping for better outcomes. The governor here opened up a lot of the non-essential services, as I discussed earlier. And so a lot of us are kind of quietly waiting to see if there's a second surge and how that works, because it's kind of an unknown right now. And those of us in the medical community are pretty concerned that there's going to be a second surge, but we're all just watching, waiting, and in light of that, trying very, very hard to get tracking and tracing available, free testing sites available, and to get a variety of different individuals in the communities that are trusted to go out and say, hey, we're here to help you. How can we help you? Are you having symptoms? Do you know someone who is having symptoms, etc., to be able to get tested and get help?
And just as we come to a close, because I know you have lots of other things to do today, I always like to make sure that people are connecting with us as individuals. Like we're doing all of these things as professionals, but we are still human beings as well, with lots of things that are going on at home. So I like to close with two questions. One is, what has been the biggest struggle for you, either professionally or personally, during the last few months? And then looking forward, what do you hope we will be the biggest gain coming out from this on the other side, especially as relates to this in the technology world? What do you think our potential innovation or creativity as it relates to technology and vulnerable populations will happen because of COVID-19?
Okay, I might have to actually repeat the second one. That's fine. I'll tackle the first question. The biggest challenge at this time, well, the first is personally, I live far away from my family. My family lives in Chicago, and my husband's family does as well. And so not being able to see them has been quite challenging for us in general. I think another issue that is very real, and that not everybody wants to talk about, is how, I'm a woman in medicine, in academia. I work in academics, and so that means that there's an expectation of publications and of research work, etc. And I have a grant through the NIH, and so there's a lot of expectations there as well. And when you're in the middle of a pandemic and there is no childcare assistance, you have to decide, if you have a two family household where both people work, you have to decide then who is going to take the hit on their academics or on their job, depending on what kind of job you have. My husband and I are both in academics, and so balancing that with childcare has been very, very challenging. There's been several articles that have demonstrated how the pandemic has negatively affected women in academics. Several articles on this topic, because for better or for worse, a lot of women do bear the brunt of now doing homeschooling. And so I'm lucky in that my child is too young to go to school yet. And so I don't have to homeschool per se. I can just kind of play and distract and things. But keeping up with academics has been particularly challenging, I'd say. And then, of course, the fear of bringing anything home. When I go to the hospital has been a little bit of a fear. Luckily, though, I have a lot of wonderful people that I work with, and we're all kind of in this together. A lot of women in medicine and academics that work together, and so we're really, I don't know what I would do without such a strong force to work with, and who kind of, we back each other up, and that's lovely. And a husband who's incredibly supportive as well. As far as the second part, so what can we do? What was the second question?
So the question is, what are you hopeful for? So there's been a lot of challenges, and we've seen a lot of negativity, if you will, and but we've also seen a lot of innovation and creativity. So what are you hopeful for on the other side? What can we learn from COVID as it relates to digital health and technology, and hopefully helping vulnerable populations?
Well, certainly telemedicine has become suddenly a hot new thing, which is super because a lot of the communities that were previously unable to access care in rural communities, and in a situation like my field with congenital heart disease, there's not everybody is skilled in that area. It's a pretty specific area. And so if you're someone with a chronic disease and there's not a lot of, and particularly as you age, there's not a lot of physicians around you that know how to take care of your particular chronic disease, like aging sickle cell individuals, aging cystic fibrosis individuals, aging congenital heart disease patients, for example, those communities, I think, will benefit significantly from the advent of telemedicine and being able to hopefully communicate more with providers in that way. And I think that that's a very, very good thing. Then, you can decide if they need to be seen, but at least then they will have access to the type of provider that they would need to some degree. There's still a dearth of adult type individuals who take care of patients with congenital heart disease, who take care of patients with cystic fibrosis, et cetera, chronic disease patients that had a pediatric issue. But I'm thinking telemedicine will help with that a significant amount. There's also been a lot of work in terms of social determinants of health as it pertains to big data. So people are now, in particular, because so many people are losing their jobs and thus losing their insurance and thus losing their health care, I'm hoping that this is kind of a wake-up call to being able to access healthcare and say, hey, if there's a pandemic and all these millions and millions of people are now unemployed and get COVID, what are we going to do now? And hopefully open up the conversation once again to saying perhaps universal healthcare is not such a bad thing, and perhaps it is necessary, but in particular, to help individuals who have been disenfranchised as of recent. That's also then true for housing and food insecurity. A lot of those things can actually also be accessed through individual portals. And I think if in medicine, if we can get more of that type of data, I think medically we'll be able to help people more too. So the awareness of social determinants of health, the awareness of the need for insurance, the awareness of accessing healthcare, I think is growing amidst this pandemic. So that's all hopeful. The one other thing I'll say about awareness and hope is this kind of brings to light the need for ongoing preventative care. I would be remiss as a pediatrician and as a public health person if I didn't bring up preventative care. And that's another thing that we were talking about a lot on the Mayor's Task Force. Is we really need the messaging to get out that, yes, you have to be very, very careful. And yes, you have to wear a mask and socially distance, et cetera. But please don't stop getting your vaccinations. Yeah. Please don't stop getting your screening. And so that general message for that to be to get out and using technology potentially to help get communities back in for those services, to reach out and get them back in for those services, I think particularly if we're doing that for COVID anyway, would be really, really helpful.
Well, thank you so much. I think that is a perfect place to end. I think there's a lot of potential. I mean, we have a lot of momentum right now around improving health inequities. I think we have a lot of potential around technology and that upswing. I'm interested to see how the telemedicine is going to continue to evolve over the next few months. And I think, like you said, we have the potential of increasing access. And we just have to make sure we don't introduce or increase barriers along with it. But I think we have so much potential. And I look forward to hearing more about what Houston is doing. I think, it looks like they could be a role model for some other large cities. And so, so we'll have to keep us posted about how that is going. But it was great to talk to you. I learned a lot from you and appreciate your time today.
Well, thank you so much for the opportunity. I have to say, being a part of the Reed Scholars was life-altering for me. I felt so strongly when I was training in pediatrics that I couldn't even put it into the words, but I wanted to do something bigger, but I couldn't describe what that bigger was. I couldn't figure out how to leverage the bigger part of it. And then a flyer came across my desk when I was a chief resident that said, do you feel like you want to do something more or bigger? And I was like, yes. And it was a flyer for the Commonwealth Health program and the Harvard School of Public Health Minority Health Policy program. And it was exactly what I wanted. And it was exactly what I couldn't articulate in order to be able to help larger swaths of the population that were disenfranchised and where health disparities existed. So I am forever grateful for the opportunity I had and becoming a Reed Scholar, because this network of individuals is the best thing since sliced bread. It's fabulous. People do amazing things. You're constantly inspired, and you always feel like you're learning more from your colleagues, and it's really an incredible network. I'm incredibly blessed to be a part of it.
I feel the exact same way, and I had a very similar experience. It was like something appeared, like, oh, like this is what I've been waiting for.
Yeah, I'm like, this is it. This is it.
So thank you so much, and we will be talking to you soon.
Sounds good.
Thank you for listening to Reed Scholars Live. Please follow us on Facebook, Twitter, or Instagram, or subscribe to our YouTube channel.